Hello, I hope everyone is having a great day so far. I'm going to talk about some challenges in the rehabilitation of COVID-positive neurological patients, more specifically chronic patients, for example, hemiplegic or hemiparetic patients suffering from COVID-19. Over the past year, Ilfov County Hospital has treated 2,162 COVID patients, out of which approximately 150 were neurological patients. About half of these received a limited form of neurorehabilitation because physical therapists were only approved to enter and work in the COVID red zones of the hospital starting February 2021. The COVID-19 pandemic has had a profound impact on the accessibility and quality of medical care, in addition to its psychological repercussions on both patients and medical personnel. With regards to accessibility, some hospitals were repurposed to receive and treat only COVID-positive patients. While it makes sense to separate COVID-positive and COVID-negative patients, this resulted in a lower number of hospitals available for any other medical issue. Additionally, some patients may have avoided going to hospitals during this period out of fear of coming into contact with a crowd of people and possibly contracting the virus, especially those with multiple chronic health problems which may have otherwise benefited from medical care. The measures adopted to prevent or reduce the spread of COVID, such as PPE, social distancing, and mask wearing, likely impacted the quality of medical care by preventing free interaction between patients and medical personnel on both a physical and psychological level. Neurorehabilitation is quite complex and involves a varied approach, including electrotherapy, massage therapy, and physical therapy, in addition to pharmacological treatment. Unfortunately, not all of these options were available to COVID-positive patients needing neurorehabilitation. During the pandemic, rehabilitation of neurological patients became challenging for several reasons. On the one hand, there are COVID-negative patients who are unable to or unwilling to go to the hospital for treatment for obvious reasons, and COVID-positive patients with mild or moderate symptoms, which are obligated to self-isolate at home. Telemedicine represents the only possible interaction with the healthcare system for these patients. On the other hand, hospitalized moderate to severe COVID-positive neurological patients come with their own set of issues, which we will discuss shortly. Telemedicine is the practice of medicine using technology to deliver care at a distance. It may include phone or video consultations or the use of email to deliver prescriptions, etc. Due to the COVID-19 pandemic, use of telemedicine has greatly increased, in some situations completely replacing outpatient care. It ensures the safety of both patients and medical staff, since no contact means no transmission. It's very safe. However, this option severely limits the extent of therapy because neurorehabilitation requires physical contact between patient and caregiver and the use of electrotherapy equipment and physical therapy equipment, which the patient likely doesn't have available at home. Hospitalized COVID-positive neurological patients requiring rehabilitation therapy are difficult to treat due to numerous factors, including the following. PPE prevents medical staff from freely interacting with patients. This is especially an issue in the case of massage therapy, as well as some forms of physical therapy, such as passive mobilization of the patient. In the case of Ilfov County Hospital, electrotherapy equipment was not available due to a lack of space. This equipment would have to be stored in a separate room, due to excessive strain on the electrical system, which was already at its limit from all the other equipment used to treat these patients. Also, patients' dependence on oxygen would have prevented them from being moved to the separate room for electrotherapy, even if there was one available. Thus, physical therapy remains the only realistic treatment option together with pharmacological therapy. However, it may be restricted by patients' dependence on oxygen, the presence of multiple tubes and wires, etc., and further limitations may arise from the specific neurological issues, COVID severity, and level of consciousness of the patient. In the context of physical therapy, neurological patients could benefit from correct positioning to prevent subluxation or the development of contractures, for example, keeping the foot at a 90-degree angle through the use of an orthosis or simply by resting it against the bedboard, a sandbag on the lateral aspect of the leg to prevent external rotation, shoulder support, and various techniques to reduce spasticity. They could benefit from techniques to improve voluntary motor control, exercises to improve balance and the coordination of transfers from lying to sitting to standing, correct walking technique with support, and respiratory rehabilitation. The consequences of prolonged bed rest with little or no mobilization may appear after as soon as 2 days of acute hospitalization, meaning the patient is confined to their bed 80 to 100% of the time. These include, but are not limited to, deep vein thrombosis, muscular atrophy, decreased muscle strength, decreased mobility, and decreased functionality. Prolonged bed rest is also associated with a longer hospital stay than would otherwise be deemed necessary for the primary disease. In addition to the aforementioned issues, which are general issues pertaining to prolonged bed rest, hemiparetic patients to begin with may already have difficulty walking, are prone to losing their balance, have prehension difficulties with their affected hand, decreased movement precision, they are easily fatigued, and tend to have poor coordination. These issues should be taken into consideration when such a patient is confined to bed rest for any period of time, as they will definitely worsen if not addressed properly. Hospital-associated disability is defined as a new loss of ability to complete one or more activities of daily living without assistance after hospital discharge. It occurs in approximately 1/3 of all hospitalized patients. Early mobilization, physical therapy, and occupational therapy have been shown to decrease the risk of hospital-associated disability, are associated with shorter hospital stays, and improve the quality of life and functionality of patients. Even in the absence of COVID, there are some difficulties in implementing early mobilization and physical therapy, including refusal of the patient, especially if they are very symptomatic, fear of falls or worsening of symptoms, or even just the general notion that the patient is too sick to move. Sometimes the issue is that there are no clear protocols for early patient mobilization. Some additional difficulties arise in the context of COVID pertaining to early mobilization and physical therapy. The respiratory issues of the patient may limit treatment. They fatigue easily, they may require an oxygen mask, or they may be intubated. Other symptoms, such as severe muscle soreness or COVID complications, for example, cardiac complications, could affect physical therapy and early mobilization as well. The duration of the therapy session is shortened for several reasons. The therapist needs additional time to don and doff the personal protective equipment. The patient may require frequent rests between exercises, so the time spent doing any kind of therapy is actually decreased. Even if the patient is less symptomatic and might be able to do more, the space available to them is limited as COVID patients are confined to their hospital rooms. Since specialized equipment is not available, therapists should focus on exercises or activities that can be done without any equipment in the patient's room. Physical therapy should focus on transfers, ambulation, and the patient's ability to perform activities of daily living with as little assistance as possible. Ideally, a section of the hospital would be dedicated for the medical rehabilitation of COVID-positive patients and would include all the necessary equipment exclusively for their use. Studies have shown that bedridden patients benefit greatly from physical therapy, especially early mobilization, which prevents excessive muscular hypertrophy, reduces complications associated with prolonged bed rest, and improves post-hospitalization functionality and quality of life. So despite the previously mentioned limitations, neurorehabilitation in the form of bedside physical therapy could help preserve muscle strength and functionality in stroke patients hospitalized for COVID-19 infection. Therefore, even in this limited capacity, neurorehabilitation may still benefit COVID-positive neurological patients, whether they are hospitalized and bedridden, or at home doing their physical therapy over video call. The physical and emotional impact which the COVID-19 pandemic has had on both patients and medical staff is impossible to quantify. It is important to study these shortcomings pertaining to healthcare in order to establish effective procedures for ensuring high quality and accessible patient care in the future. Thank you very much for your attention.